Okay, thank you again. Well, let's do some cases. You'll see this is a mix of things I hope will be relevant for you, and some good teaching points that I think can come out of this. So I call this cases from the beeper. A lot of these cases are from cases from the beeper, stuff that we get asked, and whether it's a formal consultation or a curbside. So let's get going. Here's a 60-year-old patient of yours, and she just got back from visiting her son's cabin in Vermont, or this could be Minnesota or Wisconsin or upper Midwest. She began feeling poorly about 8 days later, and she shows up with fevers, chills, myalgias, and a pretty diffuse headache. So you can see on exam she's got some things that ought to concern you. She's got a fever, but she's lucid. She's obviously not feeling well, but she's in there mentally with you. No meningismus. She does have a rash, a fever and a rash. Take a moment to soak up the labs. Let's take a look at the labs here. So the CBC, she's leukopenic, thrombocytopenic, hemoglobin's pretty good. ANC is a little low, okay? Over here, we got a transaminitis. Alk Phos looks pretty good. Bilirubin looks good. So we got cytopenias and a transaminitis. The lab calls you. The lab, wonderful lab, says, hey, we got something we want to show you on the smear. And this doesn't project quite well. This is purple, and that's blue right there. So the lab calls you and says, we got a blue thing right there we found. What's the diagnosis? Is this Babesia, anaplasma, Ehrlichia, Lyme disease, or relapsing fever? Go ahead and vote. Okay. Good deal. Oh, taking it back. There we go. All right, we got a pretty good arrangement there. Good. All right. Now, how should this infection be treated? Ceftriaxone, amoxicillin, doxycycline, levofloxacin, or the combination of azithromycin and atopiquone. Whatever she has, how should we treat it? All right. Looking like more doxy than anything else, and a little bit of this down here. Sounds good. Now, one last question. What else can you get from the tick that did this handiwork? This is the tick. What else can you get from it? Lyme disease, Babesia, Rocky Mountain, Lyme and Babesia are all of the above. What else can you get from this tick? We have had a tremendous tick-borne illness season where I practice, just a ton of it. All right, whoop, all the above, so very good. All right, let's take a look. This is a case of anaplasma, and of the tick-borne illnesses, this is one that I think it's to some extent some pattern recognition and recognition of the risks, but as well, it's one that we very much respect and fear. And what I want to get across to you is not only the epidemiology and the approach to management of anaplasma, but its partner in crime, which many of you are going to be more likely to see based on where you practice, and that's Ehrlichia. And of course, it used to be that we all lumped them together. Ehrlichiosis was divided based on what cell was infected. But of course, every few years, they have to come along and rename the organisms and do all this just to keep us on our toes. And so anaplasma is the organism that you see gets us up in my neck of the woods, but also very prominent in the eastern seaboard as well. And the tick that transmits this particular infection is the black-legged tick, the deer tick. Out west, it's a version of that. So it's the tick everyone knows and loves, especially in the upper Midwest, that likes to transmit Lyme disease as well as anaplasma. 6 states, upper Midwest, East Coast, serve as the majority of cases, but you can see it makes its way down, depending on where that tick vector is. Now, Ehrlichia touches many of you more than it does where I work, and Ehrlichia is a bacteria very similar, very close analogous to the anaplasma organism. Different tick, however, the Lone Star tick, and you can see that at least a third of the cases or more are in this particular region here. What I want to point out on the lower right there is how some of these infections work and why we have the respect for them we do. The young and the older, you can see the mortality associated with these in particular infections is not insignificant. And one of the things I want to relay to you today is some of those risks and concerns. There's new versions of these being recognized. This is one that was reported a few years ago, and with PCR techniques and others, this was a New England Journal article showing that the expanding epidemiology of bacteria similar to Anaplasma and Ehrlichia is ongoing. So we're going to have more of these, and there's going to be a geographic distribution that I think will touch all of us at some point or another. Not that this is as relevant for your practice, but just to give you a heads up that more of these are likely coming in our future. When do we see these? Well, when the ticks are out. And so both Anaplasma and Ehrlichia, you can see here predominantly summer infections. Now, I'll never forget a case a few years ago, again up in Madison, Wisconsin, where I'm at. It's December. An 89-year-old gentleman comes in densely encephalopathic, and we worked him up and thought, my gosh, if this were June or July, this would be Anaplasma. But boy, it's December, it can't be. So of course it was Anaplasma. And it was a very warm fall and early winter, kind of like what we're having now. And the ticks were alive and well. And so these are when the ticks like to do their handiwork. So predominantly summer, but certainly depending on how the environment goes, you can see it beyond those peaks. And you can see what happens with the distribution here. Any age, but the highest 65 and older. Now, the script is what I really want you to remember about these infections. And this is a flu-like illness with cytopenias and elevated transaminases. And the labs that I showed you, the white count, the thrombocytopenia with preserved hemoglobin is exactly what I look for when I'm thinking of this. And the transaminitis just fits perfectly with it. So flu-like illness, cytopenias, and LFTs. Now here are the two organisms, Anaplasma and Ehrlichia. And you can see it's a flu-like illness with some nonspecific symptoms. They're really very similar in their clinical presentation. Where they differ are the rates of rash, especially in kids. We see more of a rash with Ehrlichia than we do Anaplasma, but you can certainly still see it here as well. The labs, leukopenia, low platelets, and elevated transaminases. Now, we've had a few of these so far this year in our intensive care unit at University Hospital. Outcomes were not good, and the theme was immune-compromised hosts who get either one of these. And septic shock, ARDS, meningoencephalitis, and acute kidney injury are some of the very severe manifestations. And where we get very concerned are immune-compromised hosts, transplant, and even splenectomized hosts. So immune-compromised hosts in the tick season, they get one of these. You can have a very rapidly progressing infection that can go south on you very, very quickly. How do you diagnose Anaplasma or Ehrlichia? Well, there's three things that I'd want you to do. Number one, use your lab. And the peripheral smears are not very sensitive, but turn that around. If they call you and describe to you this blue area right here in the neutrophil, this is called a morula. This is a collection of the organisms. And one of the ways that Anaplasma and Ehrlichia differ is their tropism for the cells. So Anaplasma is the one that infects granulocytes. So this is the morula in a poly right here. Ehrlichia infects monocytes. So that's the morula in a monocytic cell. Not very high sensitivity, but if you see them, there's pathognomonic, and you work with that. Probably the most sensitive tool are the serologies right here. They're good if you get a single value or a fourfold change, acute and convalescent, can be helpful as well. PCRs are quite good, and the highest yield within 1 week onset of symptoms, and then it drops off. But what's the problem with these tests? Let's dismiss this one for a moment. What's the problem with these two guys? Expense to some extent, I would agree. Yeah. They take a while to come back, the turnaround time, right? So the bottom line with many tick-borne illnesses, but especially these, is you send those tests, you order them, but you don't wait for them, okay? So anytime you suspect either one of these infections, you treat, and you treat now. And a common pitfall that we see quite a bit in management is that desire to send the test. The clinician thinks of the possibility, sends the test, and then waits. And again, in the wrong host, that's where now we have an infection far more severe than it should have been or could have been. Now, the drug of choice, as many of you picked, is doxycycline. And just to review those other choices, Lyme disease, of course, is alive and well in many parts of the country. We've been seeing a ton of it this summer, as we have anaplasma, and not so much babesia. So the Ixodes ticks that we have up in the upper Midwest and throughout other parts of the country, Lyme disease, anaplasma, and babesiosis. The Rocky Mountain spotted fever, many of your practice sites are going to have much higher prevalence of that than where I work. That's the dermacenter tick. So you don't get Lyme disease, anaplasma, or babesia from that. So the drug of choice for all of these, if you lump them together, is doxycycline. Now here's something that I think is fascinating, and it's not as well known as I think it ought to be. But both the CDC and the pediatric folks endorse doxycycline in kids, doxycycline. And it is the drug of choice, irrespective of age. And I think that darn boards question that we all had at least once, probably more than once, the 7-year-old kid that comes in and the wrong answer is always doxycycline, right? Because of the teeth staining, doesn't apply. They've taken it out of the equation. But what's awful is that I think we learn that at such a young stage of our training that we never let go. And I'll show you a follow-up slide here in just a minute. When you think of this diagnosis and you treat, it's terrific for me in a couple reasons. One is, to be frank, you got to be a clinician here, right? You can't rely on the test because the test is going to take a week or two to come back. So you got to be a clinician, number one. Number two, if you're right, you'll know it by the next day. And that person is feeling better. This 88-year-old guy, after doxycycline, whoop, he was up and looked good. The first case of anaplasma I saw this year was in an 89-year-old guy who presented, and he was, again, densely encephalopathic. His family had been called in. He probably wasn't going to survive the night. The next day, he was up in the bed eating breakfast. It was pretty neat to see. Distinct improvement, and that rapid improvement validates our clinical suspicion. You'll also find that the hematologic parameters improve a few days in, and then the transaminases follow. So you can follow those, again, while your serology and your PCRs are cooking in order to see if you're right or not. This is one of my favorite campaigns that I'm concerned is probably the least known CDC campaign, and this is called Doxycycline Saves Lives. Let me read to you what it says here. This is from the CDC, and it's a few years old. Use it to treat suspected rickettsial infections in patients of all ages. New research shows no evidence of pediatric dental staining when used in short courses. And so the punchline for these tick-borne illnesses is when you suspect them, start doxycycline and start it now, even in kids. Anaplasma, Ehrlichia are there. Early stage Lyme disease. Remember, that's a clinical diagnosis too. Serology has no role in early localized Lyme disease. But again, it's a fooler and a common pitfall where that serology is ordered and it comes back negative. The individual's not treated on that basis, and then they go on to have some advanced complication of Lyme disease. Or the serology comes back falsely positive. There's a lot of pitfalls, as you know. Q fever is another example, starting doxycycline now. And again, why is this campaign in existence? It's not for anaplasma or Ehrlichia, but it's for Rocky Mountain spotted fever and the pediatric mortality associated with it when doxycycline is not given because of the fear of the teeth, right? So rickettsial infections, keep these in mind. Do not wait for tests. Start the drug. Start it now. And when you suspect these tick-borne infections. So here's what Ixodes can do. The early Lyme, disseminated Lyme, a whole bunch of manifestations, anaplasma or Ehrlichia. In the script, I want you to remember babesia, that some of you appropriately were concerned about, is a hemolysis malaria mimicker. So there are lab findings that the lab will help you with, much akin to a malaria smear. They'll show the classic tetrad, or look for those of the babesia organisms in the red cell. But this person would present with fatigue, hemolysis parameters, that kind of stuff. You can get any of these or all three when you encounter one of those ticks. So here's the key points about anaplasma or Ehrlichia. Recognize that script. A flu-like illness, cytopenias, LFTs equals doxycycline in my book. And if you're wrong, the harm risk is extremely low, but I sure am glad you started doxycycline, right? Start it immediately, send the test, but don't wait for them. Okay, and you'll see these cases end with some key points that I'd like to have you take away. Here's another case. This is a neat one, and I'm going to lead you through this exactly how it played out in different parts of our healthcare system in Madison. So I'm going to sort of drag you through exactly how she came through the system. This is a 24-year-old nurse at our university hospital, and she presented with a week worth of fever, chills, night sweats, some pleuritic chest pain, a dry cough, and a headache. And she has Crohn's disease, and you can see her therapies here. She's on Humira and azathioprine for the last 6 months. She works in our post-op care unit. She doesn't smoke, no pets, no farm exposure. She grew up near Cincinnati. She traveled to Tucson as a kid, and she just got back from Puerto Rico. Remember your days on the ID consult team, you asked all the questions where everybody went anywhere in their life, right? You got to do that. So that's her story. So she was seen first in urgent care, and she had stable vital signs. They noted some cervical adenopathy and crackles, and you can see her labs didn't look too bad. The white count was normal, and she had some atypical lymphocytes, okay? So this is what urgent care had. This is her x-ray, and she has a left hilar enlargement there, and this is what the radiologist told the urgent care clinician: a focal ill-defined nodular opacity in the left midlung with a prominence of the left hilum right here. This could be related to pneumonia with reactive lymph node enlargement. Primary TB could also have this appearance. Okay? So this is the radiology report the urgent care clinician got. This is their assessment and plan. And what I want you to do with this is critique it. So the urgent care assessment was community-acquired pneumonia. There is a possibility of early TB. Let's get a repeat chest x-ray in 4 weeks, quarantined until QuantiFERON gold results, wear a mask, provided N95, okay? This is the advice and the assessment. They gave her a gram of ceftriaxone and discharged her on levofloxacin, drawing blood cultures in that QuantiFERON. Agree or disagree?
It's a heck of a nice rocket launcher to use for squirrel hunting if you're thinking community-acquired pneumonia.
Okay, all right. What do you guys think? Agree or disagree with this? And yes? Wrong diagnosis? What a terrific, thank you. Your response was so wonderful to hear, actually, and a terrific study that I think is forgotten out of, I think, University of Kentucky many years ago showed the delay in diagnosis with TB and the empiric use of fluoroquinolones led to TB resistance, quinolone resistance in TB. You're exactly right. Quinolones are outstanding drugs for tuberculosis. So if you happen to use them to treat TB, whether you know it's there or not with monotherapy, of course, that's exactly what we want to avoid, right? So very good. That would be a concern. Not a good choice if you're really thinking this is tuberculosis. I'm sorry? Mononucleosis. So you're concerned about an alternative diagnosis. Good.
Or histoplasmosis. River Valley plus immunotherapy.
Okay. All right. Yes?
Also, if there's an infiltrate on that chest x-ray, who's to say it won't linger around 4 weeks later?
Right.
Get the repeat result back. It's not necessarily going to change your management. Because if it's there, you don't know if it's going to clear in the next couple of weeks or not.
Right. Yeah. No, good point. And just to highlight a couple things, and one of the reasons I wanted to share this too, and I'm not picking on the urgent care clinician here. This is a tough case. But let's just think about this a minute. What if we're concerned about active TB? How do we diagnose that?
Well, I was going to say, I don't think it's a safe thing for her to go back to the hospital setting, even quarantined in a mask.
Okay. So concerned, because you're concerned about the transmissibility if this is TB. Got it. Good. Okay. So, yes?
Transmissibility of primary TB is practically zero. The key here to differentiate what's going on is the hilar adenopathy.
Okay.
We do not see it in common pneumonia. We see it in sarcoid, which is not as aggressive a disease as you're describing. But this most likely is either histo or TB based on the fact that she's immune suppressed.
Okay. All right. Nicely said. And let's go back and just, let's say we're concerned about TB. How do we make that diagnosis? What's missing from here? Sputums, exactly. So remember, a PPD or now a quantiferon, it's easy to get, or either the T-spot, the interferon gamma release assays, they're not meant to diagnose active TB, right? Their job is to diagnose latent TB. They have no role in the diagnosis of active TB. That's where you get the sputums. Now, it isn't to say that they have a complementary role to give you an in, but they're telling you about latent TB. They're not telling you they cannot make the diagnosis of active TB. So this clinician hung their hat, if you will, on that quantiferon gold result. What about the N95? Remember, that's for us to wear, right? We wear the N95s. The patients wear a surgical mask, social distancing, stay at home. We'll follow up with the smears, which weren't ordered, but we'll stay at home, don't go to the shopping malls, all that kind of stuff. Your public health folks help you with that. But just to point out some of the subtleties. So if we're concerned about active TB, we want to get the sputums, right? The sputums are where it's at. And then, of course, you see how it played out. Now, she came back 2 days later, not any better. Not any better. She's in the ER now. Her shortness of breath got worse, fevers, night sweats, dry cough, malaise, myalgias. Her adenopathy, or at least the tenderness there, had improved a little bit, but she called in with a fever and was told to go to the ER. You can see her vital signs in the ER. She's afebrile, she's tachycardic, and pretty good sat on room air. She's got some adenopathy. Her lungs are clear. Let's soak up the labs. So we have mild thrombocytopenia and some bandemia here. And we have transaminitis right here. And then some stuff that came back either from the urgent care or things we can get rapidly in the ER. So we know at this point in time, monospot's negative, rapid strep negative, HIV negative, quantiferon came back negative from the urgent care, and the blood cultures they drew also are negative. So that's where she's at now. Here's her CT scan. So, and here's the reading. Multifocal consolidation, subpleural, non-enlarged mediastinal axillary lymph nodes, atypical infection versus organizing pneumonia, soft tissue, mass-like density left hilum, which may represent lymphadenopathy, and a mildly enlarged spleen. What's on top of your differential? Go ahead and vote. TB, primary, TB reactivated, fungal, pneumococcus, legionella, or a virus. Oh, I love it. You guys are awesome. I'll go on to the next case. You're exactly right. Now, she came back from Puerto Rico. Guess what she did? Spent a whole day in the caves. Yeah. What's on top of your differential now? I think I heard it. I love it. You guys are awesome.
Easily reactivated from her childhood if she grew up in the Ohio River Valley too.
Neat history, isn't it? So she grew up in Cincinnati, which of course I spent a year there in residency in Indianapolis too. Everybody's got histo. The whole world's got histo there, of course. And where I practice now in Madison, in Wisconsin, we're blasto, which many of you, some of your practice sites, are going to have a lot of blasto. And of course, her trips to Arizona were designed to try to give us a sense of her risk for what? Coccidiomycosis, right? So what I want to talk to you about today is the approach to pneumonia in your folks on TNF-alpha inhibitors. It's not your usual community-acquired pneumonia. And they have a higher risk of mycobacterial and fungal infections, as all of you pointed out beautifully as the case went on. The tenet that we hold on to in what I do is very simple, but there's nothing simple about it. Immune-compromised hosts mean make a diagnosis and make it fast. This is when we might have to start empiric therapy, but we never want to hang our hat on it. We do everything we can to take whatever that workup is and we compress it to the point where you aggressively work up that individual to make a diagnosis, a specific one, for several reasons. Number one, the differential is huge in many of these folks. Number two, the therapies are toxic specific and maybe off the beaten path, right? So we got to know what we're dealing with. Now, TNF does a lot of things, and when we inhibit it, it brings to the table infectious risks, predominantly of granulomatous infections and intracellular pathogens. If we look at the kinds of infections we see, everybody knows about mycobacteria. Fungi, many of you picked up on, with histo being number one. Hep B reactivation, if you haven't dealt with this now, you will at some point probably. Your folks who have an exposure history where they're not seroprotected, but they have markers for chronic active hep B, and they'll be considered to go on one of these agents, need to be referred for close monitoring and even treatment of this, and perioperative infections. So mycobacteria and fungi are alive and well, and we all know the mantra, right? And many of the time it's the subspecialist, the rheumatologist or the GI person or the dermatologist who are very proactive about appropriately screening for TB. It's the history, the physical, the IGRA or the PPD, whatever you're going to use. And if they're not, they ought to be, right? These drugs have a high risk of mycobacterial infection, and TB screening needs to be part and parcel with using these medications, as do these serologies, any other active infections. But when it comes to fungal infection, we have very little guidance, actually. It's not as clear what we should do. There's no routine screens recommended before starting a drug like Humira or the other TNF-alpha inhibitors. What if someone had a history of a deep-seated fungal infection 2 years before considering, or within 2 years before considering one of these drugs? I would urge you to refer them to somebody. If you have a local ID person or make the call or whatever. Why? Because of the risk of reactivation, which I think someone mentioned. Some may warrant serial antigen testing or preemptive therapy, and it's very individualized. There's no pat answer to that particular problem. And then ongoing risk exposure, which we'll get to in a minute. So what's the workup for pneumonia in a patient on a TNF-alpha inhibitor? I'm giving you the Cadillac Lexus workup here, right? And I would encourage you to start here and then tailor it, but start at least with this in terms of your list. It doesn't mean you order it in every patient. I do in most of the patients, but remember, I'm a narrow-minded, subspecialty bias-prone ID person, right? So I'm going to see them down here. But please remember the workup up front. Why? Because it'll save us a lot of grief if we make this diagnosis. So the routine stuff is here. Don't forget about these guys. There's a higher risk of bacterial pathogens, mycobacteria, the sputums we talked about, and here's the workup for if you're suspicious for a fungal pneumonia. So always get a smear, and always get culture, because you'll see many times your histo or blasto on that smear with a good lab microbiology technician. The antigen studies always get urine and serum. Why? Because our yield is higher when we combine both of those sites. The histoplasma antigen and the blastomyces antigen, and now the coccidiomycosis antigen studies are outstanding tests. The antibody serology for cocci is still a good test, and here are the markers that I call the quick and dirty or fungal evaluation test. The cryptococcal antigen ought to come back within hours from any place where we work, so that'll give you a leg up. These guys here, the 1,3-beta-glucan and galactomannan, are rather non-specific. They take a while to come back, but if they're elevated, it can give you a clue. And don't forget about the LDH. In cases of disseminated histo, it's pretty unusual not to have an elevated LDH. And for these pneumonias, a strong consideration to getting them worked up quickly. But let's frame this case. Let's just go back to when she was admitted, just so you get a sense of sort of the thought processes. Here we had, and as nicely pointed out, an immune-compromised host, right? TNF-alpha inhibitor, azathioprine, big league medications. This pneumonia now takes on a different light. And she was taking levofloxacin. So what's the most important question we need to ask as clinicians at the time of getting her now about that levofloxacin?
If you have a bacterial infection that's resistant to that.
That's possible. So anybody getting worse on levo makes you think could be a levofloxacin resistant case, no doubt about it. But what's a more, I would argue, what's a more common scenario? Nice. Did you take it properly? What's proper taking of a fluoroquinolone? Excellent. So I can't tell you, and my fellows roll their eyes at me when I'd say 8 times out of 10, I get money from this. Mr. Smith, how you doing? Good. Yeah, in this medicine you were on, did you take it? I did. What time did you take it? In the morning? Okay. What do you do around the time you take it? Eat breakfast? What do you have for breakfast? Fruit Loops? Do you eat Fruit Loops dry? Do you like milk? Well, of course I like milk with my Fruit Loops. Okay. What else do you have for breakfast? Orange juice? Wife's in the room. Is that calcium fortified orange juice because it's good for his bones? Sure, we buy that all the time. I also get the big jug of calcium carbonate from Costco and Sam's because it's the best thing for his bones. And so every morning we both take calcium carbonate. We have our milk on our Fruit Loops. And this is exactly how he was taking his levofloxacin, just like prescribed, Dr. Urban. What's the problem with that? Yeah, if you ask that crazy level of detail, you will be floored by this sheer number of people that take their fluoroquinolones improperly Therefore, they don't absorb it. So a possibility always is they're not taking it as they should. In this case, she was, very appropriately. I always ask those questions. 8 times out of 10, I will get an answer that they're not taking it properly, which makes me think, maybe this is something that would have responded to Levo or Cipro or Moxie, but didn't. So just I want to highlight that. Her travel history, and by this point in time, her pertinent negatives are alive and well. So as many of you pointed out, we're worried about perhaps an opportunistic fungal infection and some other opportunists there as well. Now, one of our best fellows saw her and then presented her to me and said, she didn't look so bad. She looks pretty good. I think we can hold off on empiric therapy and just see what comes back from the BAL. When I got involved, she had just been BAL'd. When I saw her, her heart rate was 136 and she was coughing to beat the band. I said, Joe, did you see the right patient? You know, what's going on here? And he said, oh, really, she looked good. She looked good. So I started her on amphotericin right away and some other antibiotics. Here's what happened. Her histoantigen studies came back quite high. This isn't a normal range because we normally shouldn't have histo in our blood or urine, but it's the range that this particular lab reports. And you can see her serum antigen was quite high, as was her urine. Her LDH was high. And then on hospital day 10, after the antigen studies came back, this beautiful picture emerges, and this is what grew from her BAL, which are the just outstanding. This is a wonderful, beautiful picture of histoplasma. So histoplasma and TNF-alpha inhibitors is a big deal. 3-fold more common than TB as a cause of serious infections. It's the most common fungal pathogen in these folks. And look at what can happen with the delay in diagnosis. Most of these present with a pulmonary syndrome, as well as disseminated histo, which can be a protein infection, right? The manifestations are just tremendous. The ecology, I'm not going to belabor because many of you are certainly well aware of this, but it's the Ohio River, Mississippi, the riverbeds around the country, and those are the most highly endemic. But of course, neat studies like this done many years ago in Navy recruits show us just how widespread histoplasma is. It likes to grow in bird and bat poop, and when you disrupt the soil, so some of the outbreaks in Indianapolis from new home construction and neighborhood development and so forth, when people inhale it are just very well described. Spelunkers, of course, and those who are around these sorts of activities. The diagnosis should be made by antigen testing and also looking for it microbiologically with a fungal smear. And then let's say the BAL or a bone marrow exam or a liver biopsy or spinal fluid. All of these should be sent for fungal cultures, but also you can send it for antigen as well. The management, most of them will get amphotericin followed by an azole for many months. We stop the TNF-alpha inhibitor, and then of course a common question is, hey, when can I restart it for her Crohn's disease or for the psoriasis or whatever? And there's a lot of follow-up that takes place. Now, here's the real reason there's 2 reasons I wanted to present this to you. To have it on your list, right? It's not your usual community-acquired pneumonia, but she got me very interested in this element here, which directly relates to primary care. Because if you look at our journals and you look at all the ads during the World Series and all that, it's all about TB, PPD, appropriately so, not putting that down. But how much information do they tell us about the risk for fungal infection? And she asked me this question, Dr. Urban, I wouldn't have gone in those caves, but no one told me not to go in the caves. I'm having fun in Puerto Rico. This is from the Humira website. All the red arrows is their concern about TB. Here's the one reference to fungi right here. There's one of them. So it got me really scouting and scouring the websites for patient education, because people really ought to be more informed than they are. And this was a highly informed patient about her Crohn's and the risks. So this table I have shared with all the rheumatologists in Madison, Wisconsin, many of the GI docs, and I'm working on the dermatologists now. And I want to share it with you. It's the only thing I found, and it came out of this terrific paper in 2010 about advice to patients regarding histoplasma. Before starting TNF blockers, tell your doctor about all these things here. During, avoid exposure, tell your doctor about possible exposure, et cetera. You get the point. Please share this with your patients, or please have it accessible when you're going to see someone with Crohn's or psoriasis or RA or whatever before the rheumatologists get a hold of them and start the TNF-alpha drugs. So the key points, think outside the normal box when patients on biologics present, make it a fast, efficient workup, and patient education for these folks, in addition to TB, ought to include something about fungal risks. Okay, here's a neat case. I just saw her a few months ago. She's a 19-year-old college student at UW, and she was at urgent care 2 days ago. So we're going to see her at the point of coming into the university hospital, but 2 days ago she was in urgent care, sore throat, cough, achy, left-sided neck, swollen glands, fever for 5 days. At the urgent care, you see right here, 126, good pulse ox, no rash. She had a little bit of posterior oropharyngeal erythema. Your ears looked fine. Rapid strep was negative. They did the strep culture, which of course is going to take a little while, and they attributed her tachycardia to fluids. Indeed, after 2 liters of fluid, tachycardia resolved. So their assessment was acute pharyngitis volume depletion, makes sense. And to quote the urgent care clinician, discussed the viral etiology of the patient's illness and discouraged antibiotic use. Excellent stewardship, supported by the Centaur score of 1. So not picking on the clinician here. This was good decision making for the data at the time, right? 2 days later, comes into our ER, more short of breath, more chills, and now you see a little different story. She's hypotensive, she's tachycardic, and tachypnic. And she's in moderate distress, only partial sentences, still has some posterior oropharyngeal erythema, no tonsillar exudates. She has some adenopathy, and she's tachycardic. Let's take a look at her labs. Her white count's normal, but she's got a lot of bands. Her platelets are low, and her creatinine looks good. Bili's up a little bit, lactate's up a little bit, okay? So sick lady here, got the picture. What would you do next? Repeat the rapid strep screen, check on that throat culture from the urgent care, and give her amoxicillin if it's positive, give empiric azithromycin, admit her for IV antibiotics, or order a monospot. What would you do next? All right. What's that? Septic appearing. All right, I like it. Curb 65, not very high? That's right. Yeah, her Centaur score was low too, right? So yeah, nice job, everyone. So let's take a look. What's highest on the differential? Mono, bacterial pharyngitis, sepsis, Coxsackie pharyngitis, or acute HIV? Okay, yeah, and it mirrors what you all said you would be ordering and concerning, and all your concerns are valid here, right? Well, there's your CT scan. And her blood cultures quickly grew Fusobacterium necrophorum. Yep. So let's talk about this organism. And I'm going to, in the next 2 minutes, try to convince you that this isn't just an esoteric ID tertiary care thing. And if I don't sell you in the next 30 seconds, I'm going to show you a very important study. I argue one of the most important studies in subspecialty and primary care to come down the pike in a long time to try to convince you. This is a bug we've known about for a long time. It's a gram-negative anaerobe. It requires special media. It doesn't grow on the routine strep screen cultures or any of that. And thankfully, it grows from blood cultures, but it takes a while sometimes. It's characterized by a lot of drug resistance. So it's resistant to macrolides, tetracyclines, and quinolones. So the CDC tells us that the #1 prescribed drug for bacterial pharyngitis is azithromycin. Should it be? No, right? The rates of azithromycin resistance group A strep are absolutely climbing, as they are to Clinda and tetracycline. Guess what antibiotic group A strep has never developed resistance to? Ever. Penicillin, right? It's amazing. So penicillin, beta-lactams are the drug of choice. One of the reasons this organism is flourishing is because of all of our empiric macrolide use. It's the most common cause of a peritonsillar abscess, and it causes Lemierre syndrome. Lemierre syndrome is a devastating infection. It's septic thrombophlebitis of the IJ within emboli north and south. So a common presentation is septic pulmonary emboli, empyema in a sick person. Pretty good mortality, right? Now, this is the pathogenesis, which I won't lead you through necessarily because I just said it, but here's the organism, it invades, here's the clot, and here's the septic pulmonary emboli. So people come in pretty darn sick with Fusobacterium. And this is an emerging infectious disease. Why? The empiric use of things like macrolides, its resistance has caused it to prosper and flourish, basically. And remember, what's the mantra? What's sort of the approach to pharyngitis, bacterial pharyngitis this day and age, and has been for a while? It's really to be very group A strep-ocentric, right? No antibiotics if it's non-group A strep, and the macrolide used for group A strep. But I want you to remember this, as someone with a progressive sore throat, fever, pneumonia, and sepsis. This has to be high on your list. Now, this is the study I hope you take home, and it convinces you, because it sure convinced me as to the value of this case. This was a study done at UAB, 300 students in their student health, and symptomatic pharyngitis as well as asymptomatic carriage. 4 organisms, PCR-based detection. So they looked for group A strep, they looked for group C or group G, which remember can cause terrible sore throats just like group A strep, mycoplasma, and Fusobacterium. Look what led the list in this college age group, both symptomatic and asymptomatic, right? 20% Fusobacterium, 9% Fusobacterium, by far the most common isolate, the most common organism from these young folks, right? Scary study. What do we do with this in practice? Gosh, I wish I could tell you the answer to that. Should we be actively looking for and treating it? We don't know. We do know that epidemiologically, Lemierre from Fusobacterium is much more common than rheumatic fever from group A strep, for example, okay? If we found it, would giving antibiotics prevent Lemierre? We don't know, but we do know that if we diagnose and treat Lemierre early, it improves outcomes. If I elected to treat a bad sore throat empirically, what should I use? Penicillin or amoxicillin, any beta-lactam, but not a macrolide, okay? So we all know we get in that gamut sometimes. The person's sick, the Centaur score says whatever, but gosh darn it, I'm gonna treat. A little bit off guidelines, but you know, many years ago now, the Internal Medicine Society said, you get a high Centaur score, even if your rapid strep's negative, you could certainly consider using a beta-lactam. So if you are in that situation, use a beta-lactam, not a macrolide. When should you be thinking about it? Young adult, worsening sore throat, and they look sick, okay? This is the differential that I like to bring up. And this is not just the sore throat anymore, right? So think about the guidelines. And even my own society, the Infectious Disease Society, our guidelines on pharyngitis are just about how to work up and treat group A strep. Sure, they have a table of a differential, but they really don't highlight it because everything's about group A strep or not, right? But if we're in this particular situation, think about non-group A strep, or maybe a rare but rapid false negative here. Many of you picked mono, and I couldn't agree more. She needs an assessment. Severe mono can mimic sepsis, obviously, and be just as bad. Remember acute HIV, and this is probably one of the biggest differentials to include. With the rapid HIV test now, we can figure this out very quickly. Focal considerations, gonorrhea, this guy, and then the danger stuff like epiglottitis and Ludwig's and so forth, right? So this is the gamut of this isn't acting like a run-of-the-mill sore throat. And the concern of many authors in this field right now is that some of the time clinicians will apply kind of that initial algorithm to someone like this, still thinking group A strep or not, as opposed to shifting to this differential, which is what she fit in. She's well beyond that 3 to 5 day time period where a viral pharyngitis ought to be getting better. So here's the key points. Young adult, consider Fusobacterium. If they're sick enough, like many of you chose, admitter, IV antibiotics, CT scan. Remember the worsening pharyngitis differential and not the strep or not strep. And then talk to your lab when you get home. Hey, if we had many cases, what would it take if I wanted to look for this? What would I order? And your lab will help you, but it's not part and parcel with the usual algorithms, okay? All right. Oh, my favorite stuff. I'm a skin and soft tissue nut, so can I get questions at the end? Yeah, thanks. Yeah. All right, here's a 57-year-old guy. I met him about a year ago. He's healthy. He's hospitalized at the time. He's healthy. He's got chronic left lower extremity edema after a motor vehicle accident, and he was hospitalized for cellulitis of that left leg. He came in with a fever, a white count, and the usual kind of merry-go-round of antibiotics. Blood cultures were negative, and they did an MRI. It showed cellulitis, but no abscess and no osteo. So what's fun in clinical medicine is getting a good history, so I talked to he and his wife and said, how did this start, or what was the deal? Well, we had a bunch of people over for football, this was a year ago, cleaning up. I was walking up the stairs of my house with dishes, and wham, just out of the blue, man, my leg started hurting and I just felt rotten, okay? Oh, I was doing great all day, and wham, just hit me like a ton of bricks. What is this? classic MRSA, classic Staph aureus, but not bad enough to be MRSA, classic strep, classic Ehrlichiosis, or classic Vibrio. What do you guys think? Okay, all right. You kind of see yeah, I like that. All right, yeah, good deal. This is classic strep. This is what strep loves to do. And the history is such that it really gives us a diagnosis. Now, if I throw in what many of you, of course, are much more experienced at than I, that's shrimper, the saltwater exposure, I cut my hand on stone crabs the other day, all that stuff, you bet, a rapid progressive cellulitis in the setting of saltwater exposure, Vibrio is alive and well. Up my neck of the woods, and many of your settings, freshwater, that's where that Ehrlichiosis comes in. But of course, the whole world of skin and soft tissue infection is all about staph and MRSA. And that's exactly the reason why I present this case, because strep is alive and well. Strep loves to get deep. Staph, remember, coagulase, Staph aureus loves to kind of wall itself off and sit there. It might progress a centimeter every couple days. Strep runs deep, gets in the deep areas of the skin along that subcutaneous layer where we have the neurovascular bundles and the lymphatics, and it can go a centimeter an hour. It has the ability to carve out those tissues and progress rapidly. That history of I was fine, and then I remember at 11 o'clock in the morning, bam, my leg started hurting on my arm, is just classic group A strep. Not much else works that way. When I hear that history, I actually take it and run with it. Streptococci loves the lymphatics. That's where we get lymphangitis. That's where we get a arm post-mastectomy that'll never be unswollen and at major risk for recurrent infection. And of course, erysipelas. This is what we're supposed to call it in 2016, non-purulent cellulitis. I call it good old-fashioned garden variety cellulitis that we all saw during our residency. It's just flat, no pus, no boil, none of that. It's indurated, it's warm, and it's overwhelmingly strep, even this day and age. In fact, this study shows that. The role of beta hemolytic strep in these kinds of cellulitis in the contemporary era, you can see that overwhelmingly, upper 90% were beta strep, and they responded to beta-lactams. So not vancomycin, not TMP sulfa, right? Purulent cellulitis is the other kind, and this is what community-acquired MRSA has really ushered in. So a cellulitis associated with a cutaneous abscess, a boil, a furuncle, a carbuncle, is overwhelmingly Staph aureus and MRSA. Now, I talked to him a little more that day, and in my mind, he very much had strep when I talked to him. And his wife said something very interesting, almost kind of insidious. She goes, after he described that, she said, "Every episode is that way." And I said, "Whoa, wait a minute. What do you mean? How many episodes total?" And just like they had rehearsed and had been through this before, they said 13 altogether. They're a good couple. This is the third episode so far this year. In a case like this, what's the most important aspect of long-term management? Oh, yeah. This is the best ARS question you're ever going to get, isn't it? All right. The only reason to vote is to see what your favorite letter is, right? Let's talk about recurrent cellulitis. In my opinion, top 3 poorly done education that any of us, no matter if we're physicians, MD, DO, nurse practitioners, PAs, we get taught very improperly about managing recurrent cellulitis. It's a vicious cycle. Lymphedema and cellulitis drive one another, and let's go through it. The cycle needs to be interrupted. We need to work on the predisposing factors and break this cycle. And there's 3 components. Lymphedema management is far and away the most important. Tinea pedis and wound management to close the portal of entry, and then strong consideration in the right person, right individual for long-term antibiotic prophylaxis. So these massive lymphedema cases like we see are horrific, and this is an extreme example of it. And this person's at major risk for recurrent infection. Bugs love water. They love edema, and this is all about edema management. Lymphedema is this, not this. So in this particular case, and the last all of them I see, the theme is very similar. It's someone not responding in the hospital to IV antibiotics. It has to be necrotizing fasciitis or an abscess or something else. The parade of antibiotics, the MRIs, all that stuff. But 99.9 times out of 100, it's this. I walk in the room and the patient had their legs in that recliner position right there. I met a guy just a couple months ago, terrific farmer from our area, 88 years old. I said, sir, I think I know the answer. I think we need to get your legs up much higher above the level of your heart. I've been telling them that for 3 days. My cellulitis gets better a lot quicker at home when I can elevate it than in this gosh darn hospital of yours. Okay, sir, I'm with you. And what I usually do is I make a big production of it. I get a big stack of pillows, I get the family members, I get the nursing staff, and I get kind of silly with it. But I say, this is what I want. And tomorrow, when I come back, Mr. Smith, I want to see you look like this. Okay, you got it. And I tell you what, the family buy-in, the patient buy-in, it's unbelievable. By the next day, things are already much improved. It is all about edema management, and diuretics do not help this kind of edema at all, okay? Now, Larry Badur started a wonderful career, in part, by recognizing this association. And what happened with this back in the day of a lot of saphenous vein harvesting for cabbages, these people would come back with 10, 15, 20 bouts of recurrent cellulitis. Wham, one right after another. And he recognized that if you wipe out the tinea pedis, the problem goes away. So 1 million years ago, I would attend on the general medical wards at our VA hospital. And a medical student once, senior medical student, heard me give this sort of talk, and I talked about the tinea pedis. The next day on rounds, he says, Dr. Urban, we have 14 patients on our service, and last night after your talk, I went and I looked at every one of them. And I'm here today to report 8 of our 14 people have tinea pedis, and by the time I'm done with my rotation, I'm going to wipe out tinea from all of our patients. I said, hey, that's great. Great, very successful dermatologist. So, antibiotics. This study I'll reference for you, and there's many other studies in the literature. This is a few years ago in the New England Journal. 270 patients with recurrent cellulitis, double-blind randomized placebo-controlled trial for a year of PEN-VK low dose versus placebo. And they excluded some patients that unfortunately are very commonly afflicted with this, people with leg ulcerations or surgery or penetrating trauma. So a lot of people that actually make up the predominance of what we see in clinical practice. You can see the characteristics of the BMI. A lot of them had chronic edema, and a third of them or more had tinea. So what they did is they gave 1 year's worth of penicillin, and then they stopped it, and they had a follow-up period. So this allowed us to see what effect penicillin had. And it had a 45% reduction, so that showed it worked. When they stopped the penicillin, you can see that the effect was not sustained. So their risk went back up compared to the folks that got placebo. Okay? Here's a table about prophylaxis failure. And what this shows us is that the number of previous episodes, each bout sets you up for the next one. So remember, our guy had 13 episodes, and here's what happens. This amazing system we have, this wonderful system called the lymphatic system, which we take for granted, each bout of cellulitis destroys some of those microlymphatic channels. They're irreplaceable, but there's a lot of redundancy. First bout or two, no big deal. But you've all seen, I'm sure, some of these folks that get recurrent bouts. You get irreparable damage to the lymphatic system, and now you're left with a chronically swollen extremity. It can't recover, at high risk for getting recurrent bouts. So each episode sets you up for the next one. You got to treat the edema, use a higher dose with high BMI patients, and I don't agree at all with their definition of failure. I know they had to do this for a clinical trial. But what I tell patients is that what to expect from your penicillin, we want to decrease the frequency, decrease the severity, or both. And we're going to give it a year and see how successful we are. And you're talking about folks that might get admitted to the hospital 5, 6 times a year. We can keep them out of the hospital. We've done a major victory, even if they get a mild case, right? So this wonderful slide, you can't read it all, from my terrific colleague, Dr. Mackey, who undoubtedly many of you know, Dennis Mackey, shows that penicillin, 0 episodes after use of the antibiotic. I love this because it's from JAMA 1966. Long-term antibiotic prophylaxis, here's a clindamycin study. Nice job in decreasing recurrence. Here's an erythromycin study. I wouldn't recommend using it because we have better choices, but just to show you that low-dose antibiotics work. So my approach to recurrent cellulitis, 1 episode in a body part where you can't reverse the edema. A perfect example is that swollen arm post-mastectomy and lymph node dissection. Swollen leg after pelvic XRT, whatever the problem is, or more than 2 episodes, same body part within a year, low-dose antibiotics, right? PEN-VK, no C. diff from this, well tolerated. If you want to use benzathine, you can. We desensitize people to penicillin. Get them on it. Why? It's so much better than, say, cephalexin. Why? C. diff risk is night and day. They're going to be on this for a long time. So don't be afraid to do this. What do I say? Give it a year and let's see how it goes. Most people, you're successful, and then at the same time, the highest priority is managing lymphedema in any wounds they have. And you'll find that this works. This works. So back to our case, his blood cultures were negative. His MRSA PCRs, appropriately done, were negative. I switched him to penicillin IV, then I switched him to PenVK. He had tinea, so we wiped it out, sent him to PT for custom stockings to use when he was an outpatient, and low-dose PenVK, and look at that. I have had so much fun with the ASOs in the last year. I order them now on everybody with a skin and soft tissue infection because my residents and fellows are so skeptical. Oh, that's not strep. Come on, you old guy. That's got to be MRSA because everything's MRSA. Well, look at that. And I'm making a slide that has all of these recent patients where the ASO titers skyrocketed. I love it. Now, for completeness, let's talk about the other thing we all see. What about recurrent boils? This is how I approach recurrent boils. So again, shifting gears, radically different topic, but a recurrent skin and soft tissue infection. First, I set expectations. I say, there's a good chance I am not going to get anything that's going to make this problem go completely away. If we help, that's great. If we can make it go away, that's great. But please don't expect it to completely go away. Some people will get these despite whatever we do. I swab the nares, groin, and axilla for Staph aureus. Why? Because I want to know where it is. Most of the time it's here. And what do we do as human beings, right? Why do people get furuncles all over them, right? The staph carriage, anterior nares, right? But we also want to look groin axilla. Chlorhexidine bathing, we don't know how long to tell people to keep it on. I tell people at least 20 minutes, but we actually don't know the answer to that. What do most people do when we have them go get the chlorhexidine? This is pre-op or for this? Well, they're in the shower. Here's that bottle, pink stuff. What happens to the chlorhexidine? It gets washed down the drain. What happens to the bugs on the skin? Nothing, because it's all about contact time. So I tell people, leave it on for at least 20 minutes until you're uncomfortable with the stickiness, and then wash it off, because then it's done some good. Household fomite and loved one management, what's this all about? Last year, our ID meetings had a wonderful study presented on the importance of fomites in recurrent boils. Doorknobs, keyboards, all this stuff. So I send people to two websites. One is the CDC right here. This is environmental disinfecting and cleansing for MRSA, the products that can work on household items to help decrease MRSA. It's a big deal. That's a nice, important adjunct to how we manage. This is from our own Department of Health and Human Services, and I've yet to find a better resource to hand. I always print it out for patients because it has highly specific, this is how much you want to launder your bed linens, at what temperature, and for how long, and these are the things you tell your family. It is the best patient-oriented MRSA management. And then loved one management, what does that mean? Many of these folks have a spouse who is a healthcare worker, right? And always ask about if they've been tested. What about family members with recurrent boils? Paracin and the nares, this is what I call the core approach right here. Only 5 days. Don't give them forever because you just get resistance. Occasionally, we got to give doxycycline decolonization, but if you do, it's short-lived. It just doesn't sometimes I use it to kind of break a cycle where trying this doesn't work. So sometimes we'll do this, but it's short-lived when you do it. This is what we have on that Department of Health and Human Services website. Please access it and use it. If you don't have a substitute, it's really good. Okay, how are we doing on time? Okay, perfect. I'm an HIV doc, so I had to throw one thing in here for you, HIV-wise. 34-year-old HIV, well-controlled, in your clinic, seasonal allergies. We've had a horrible allergy season up where I practice. And it's been tough, a lot of congestion. He uses loratadine PRN. He takes Genvoya for his HIV. His CD4 count's high and his viral load's undetectable. Doing well from the HIV standpoint. What would you recommend for his seasonal allergies and someone taking PRN antihistamine? Fluticasone nasal prescription, fluticasone over the counter, beclomethasone, changed to fexofenadine, or a neti pot. Go ahead and vote. Most of our state's population is on a neti pot. It seems everybody likes their neti pots. Yeah. Okay, so sort of a spectrum, but if we add it up, we get over 50% fluticasone, which is a wonderful drug, of course. Let's highlight that. And I agree with nothing wrong with this, only if the water is done properly, right? We get the Pseudomonas and the bad gram-negatives that come from improper neti pot water preparation. And let's highlight this, and then the absence of beclomethasone. So what's new in HIV? And of course, I love talking about HIV more than anything, but our patients are doing great. These meds are simpler, they're well tolerated, they're highly successful. The comorbidities that we're seeing and managing with so many of our excellent primary care docs in my neck of the woods are cardiovascular risk, non-AIDS defining cancers, a lot of bone health issues, a lot of osteopenia and osteoporosis. Fourth generation HIV testing, which is a huge topic in and of itself, is a brand new way to make the diagnosis. I bet every place that you work is using that now, and the Western blot is gone. We don't use that anymore, so it's a whole different way of diagnosing HIV. Prevention efforts are trying to be engaged. The most successful way to prevent HIV is actually to treat and get the viral load undetectable, and that makes the transmission risk extremely low. PrEP, pre-exposure prophylaxis, short, and it's taken a while to come up, but more and more people are using that. This is what we use now in a lot of folks. They're called single tablet regimens, 3 or 4 medicines in one tablet. So gone are the days, the first protease inhibitor that came out, was the size of your coffee cup, and you had to take, 6 of them 3 times a day with food, and that was only one of your meds. Now we have these amazing fixed dose combinations, single tablet regimens. All of the meds are right here for that individual. This is what they take for HIV. So we have a lot of choices now. Fixed dose combinations, not unique to HIV, right? There's combined diuretic and ACE inhibitors, cholesterol meds. We all are familiar with this, but let's take a moment to go through this. Most people being treated for HIV now are on a fixed dose combination where 2, 3, or 4 medicines are in one. Nobody will call them by their generic names. If they know what they're on, they're all going to call it by their trade name. Creatinine clearance matters because some of these components of these fixed dose combinations have to be altered in their dose depending on creatinine clearance. And be aware of hidden PK boosters. Your EHR will not save you at all in this particular case. Your EHR is effectively paralyzed when it comes to this, just in seeing innumerable cases of drug interactions that the thing misses. Let's take this as an example. This gentleman's on Genvoya. So what in the world is Genvoya? It's got a medicine called TAF, which is tenofovir alafenamide, and its major adverse effects are acute kidney injury, Fanconi syndrome, and bone health. Less so than its previous version called tenofovir DF. Emtricitabine, both of these drugs need to be adjusted in renal impairment. These are both nucleoside reverse transcriptase inhibitors. Cobicostat, what's cobicostat? It's a potent P450 inhibitor that has no anti-HIV properties. It's there specifically as a pharmacokinetic booster of this drug called elvitegravir. Elvitegravir is an integrase inhibitor. Given by itself, doesn't do anything. Given with cobicostat, high levels, outstanding way to treat HIV. Cobicostat is buried in a lot of our fixed dose combinations. It's a potent P450 inhibitor, okay? So let's take a look at what we're getting at here. Drug interactions. Always been a problem, always a concern, and P450 is where most of what we run into is the problem because our protease inhibitors, this cobicostat medicine, and some others are all very potent, active, the P450 system. So what general medicine meds come down the pike? A lot of statins, steroids, PDE5 inhibitors, anticoagulants, a lot of antibiotics, calcium blockers, and many others. Always look up any new meds for interactions. My pharmacists and myself, we have Lexicomp in our EHR. We get called a lot, which we never mind. This is from the antiretroviral guidelines, which you can't see, but it actually is talking about corticosteroid use in HIV medicines. So what's the problem? He's on Genvoya. This has cobicostat, and corticosteroids are 3A4 metabolized. These are the data. We are now up to about 12 cases of Cushing's that transitions to Addison's because of either inhaled or intranasal or injected corticosteroid. So here's some of the first reports, inhaled, and then injectable corticosteroids. This is a healthy volunteer study. There's only 2 PK studies out there. This is from GSK's package insert of fluticasone. And this is using fluticasone nasal, so not lung, nasal, with ritonavir, one of the protease inhibitors. Look what happens to the Cmax. It goes up 25-fold. Look what happens to the area under the curve of fluticasone. It goes up 350-fold when co-administered. Unbelievable. So the management options for patients on protease inhibitors is actually to use beclomethasone. So a lot of the patients I co-manage with COPD, asthma, allergies, it's a strong message to kind of make sure the pulmonologist or allergist or primary care understands this interaction. And I will change my HIV meds if I have to alleviate the interaction, and that's important to know. But if we have to broach it, then beclomethasone, which has been studied, is safe to use as a corticosteroid when someone is on a protease inhibitor or cobicostat. Injectable is one that's driving us crazy. You know why? Because someone goes in for their epidural or their knee, and the rheumatologist or the radiologist, they pull it off the shelf, load up their syringe, and boom, just like they've always done. It doesn't go through any EHR drug interaction check at all. So our rheumatologists are now very aware of this, and it's a big deal. So like I say, I will sometimes change the antiretrovirals if I know that they're getting a procedure, but many times I don't know they're getting a procedure. So the key points. Recognize most patients with HIV are taking a fixed dose combination. Here's what you need to do. Deconstruct their HIV medicine into its components, and then be wary of the components that have a lot of drug interaction potential or that you have to dose adjust for renal impairment. The two red flags I want you to remember are ritonavir and cobicostat, and always call for advice, and then have corticosteroids up on your list of potential drug interacting compounds. Okay, those are the cases today. Recognizing Ehrlichia and anaplasma, the pneumonia workup, recognizing and remembering Fuso, recurrent cellulitis, and a little bit on HIV drug interactions. Your questions have been awesome today. Thanks for them, and I'll be here for a little bit if there's still some more. Happy to address them, so thank you.